स्केटिंग रिंग होता है ना, आइस स्केटिंग रिंग रिंग ये कैसे पढ़ रही है? अभी तुम इंग्लिश तुम अपना ना नहीं लाते हो। हाँ चेक करो सारा होमवर्क का प्रोजेक्ट वर्किंग नहीं और जो मंडे से पहले ला
Now you can mute yourself. Dr. Ashok, I was calling. I think you already joined.
Yeah. I'm available, sir.
Good evening, sir.
Dr. TD joins, then you can start.
Okay,
He's
sir.
joining just in a moment. I think Dr. TD has joined, so we can start. TD sir can take over.
Good
Hello.
evening, sir.
Yes. Sir.
Yes.
Good
Good evening.
afternoon. Yes.
Yes, sir. Good.
So one more moderator is there.
But two had joined. I think can start. He will join. I'll just call him.
Okay,
So
let's
Maas is
start. Dr. Rishit. Okay, go ahead.
Yes, sir. Yes, thank you, sir. Good evening, respected faculty. I am Rishit Mani from AIMS Patna, presenting today a case presentations. A 66-year-old lady who's a homemaker, a resident of Muzaffarpur, presented with us with the yellow discoloration of eyes and urine from last 1 month. Patient was apparently well 1 month back when she noticed yellowish discoloration of her eyes and darkening of urine, which was insidious in onset, gradually progressive in nature. There was no history of waxing and waning. It was associated with passage of clay-colored stool, generalized pruritus, which was more pronounced at night, causing moderate discomfort but not significantly affecting the sleep. She also having a decreased appetite and subjective weight loss, which is evident by loosening of her clothes, although the exact amount of the weight loss could not be quantified. There was no history of recurrent episodes of upper abdominal pain or dyspepsia in the past. She also not giving history of previous history of jaundice, recent onset diabetes mellitus. There is no history of fever, chills, or rigor. She's also not giving history of nausea, vomiting, or postprandial fullness. There was no hematemesis or melena. Also, there was no easy bruisability, spontaneous bleeding, or decreased night vision. There was no abdominal distension, shortness of breath, persistent cough, or other respiratory symptoms. She also denied history of persistent headache, seizure, or blackout, back pain, or bony pain. On past medical and personal and family history, she is known hypertensive and hypothyroidism on medication on a regular basis. There is no. She is a postmenopausal woman consuming mixed diet. She's said that appetite has decreased since onset of the jaundice. No history of alcohol, smoking, or tobacco use. There is no family history of hepatobiliary or gastrointestinal malignancies. So, based on history, my summary
So
is
you go, yes, go ahead.
yes, sir. Based on history, my summary is a 66-year-old female with a well-controlled comorbidity with 1 month history of painless progressive surgical obstructive jaundice with decreased appetite and weight loss without history of cholangitis.
Can you go to your multiple no history in that point?
Yes, sir.
So why are you telling that there is no previous episodes of jaundice? What we want to exclude or want to tell the people who are listening to you?
Yes, I want to tell that in cases previous history of jaundice, cases of cholelithiasis can be there.
Okay, so it goes into past history. Okay, suppose somebody has cholelithiasis and today presents with the jaundice. So the cholelithiasis will be past history.
No, sir. In that situation, it will come into the history of
And
present diabetes.
why you are talking about persistent headache and blackouts?
So generally for metastatic, these histories are asked, sir.
Okay, so you are talking, this thing you are giving, no, it's not a MBBS. So what
Yes, sir.
percent of the people who came to you with a jaundice, suppose there is malignancy, and you have seen that presented with the blackouts and headache in your whatever 2.5 years of at least might have completed in MCH and then 3 years in MBI, this thing. So what I mean to say, it's very important to talk the relevant things which helps in your this history. Go to summary now, please. So your first diagnosis is carcinoma gallbladder, neck with hilar involvement. Okay.
Yes, sir.
So the second is periampullary.
Yes, sir.
Can you just go one by one? Why you want to say it is carcinoma gallbladder? If I am at your place, I will try to know that what is the duration difference between the pruritus and jaundice, start of jaundice.
So she complained along with that. When she noticed the jaundice after next week, she also complained that she started having a pruritus, which is gradually progressive in nature.
How will you explain? What does pruritus mean?
That pruritus means that that her jaundice is worsening during the course of her time.
Oh, is it so?
So this may be because of the allergy or some infestation, scabies or something. Why you're saying this is related with the jaundice, especially?
In cases of jaundice, pruritus usually happen because of when there is an increased level of jaundice that can cause deposition of bile salt in the peripheral nerves endings, subcutaneous nerve endings, that can cause pruritus.
No, I'm not asking you why it's happening. I'm asking why is connecting the jaundice with the pruritus. It could be some other reason. Maybe the
That
jaundice may
is
not have a
that is connect that
yeah.
is connected because of the obstructive nature that help in deciding the obstructive
So
nature.
this is coincidence. This must be a coincidence. So I just want to know how you just specifically say that this pruritus is because of the jaundice. What is the characteristics of the pruritus occur in the jaundice?
Uh, Pruritus is mostly in cases of jaundice, most happen in the night, which is central in locations, and
Where? Where's occur? Maybe in the night, all kind of the pruritus can very much appreciated at the night. Where is occur?
it basically occurs in central part of the abdomen. Yes, sir.
Center part of the abdomen.
But basically, you start from the central, then the extremities. So,
Which extremities? Where? What is the characteristic of the nail when the patient have a very intensive kind of jaundice because pruritus because jaundice? You may look for this some specific site, nail, the extremities. You say, so where you look for?
on extremities, there is scratch marks also, and there is nails or
Upper extremities or lower extremities?
upper extremities.
You're not read carefully.
Okay.
So my intention to ask the question was, yes, yes, somebody was trying to say something. Hello, am I
Hello.
audible?
Yes.
So my intention to ask this question was, in a patient where jaundice and this pruritus start simultaneously, usually what happens that if there is a complete blockage, then there is a pruritus. Even if there is a minimum this thing partial blockage, usually pruritus is not there. So you should know this. That's why when we talk about hilar block, you come to know that there is a pruritus which starts very early in comparison to the ampullary and periampullary tumors. So that is the reason. It's not like that it starts simultaneously because it is a bile salt goes. When how many times in a choledocholitis where we think there is a partial blockage, usually pruritus is not that common. But on the other hand, if there is a complete blockage which happens in malignancy, so usually it's a this complete block. So you should know this very clearly. So why you are saying carcinoma gallbladder? Your
So
first
because
question.
yes, sir. Because
Please.
of 66-year-old female.
That we know. Something we know we don't want to know. You tell that this is the 60-year female is prone for malignancy. Carcinoma gallbladder. One is
because
that. Uh, uh,
because of sir high endemic zone area of
so the
northern part
first
of
is you are talking about because this is endemic zone. That is very relevant answer. Second.
second old age female with progressive jaundice, sir.
So only two important points. So if I say same is true for the carcinoma pancreas, why it's not carcinoma pancreas?
So it the based on the sir the high endemic zone of our area ahead.
One important point already accepted. Why are you repeating? You said I accepted. Any other important point?
It is a painless progression, sir.
So gallbladder cancer, painless progression. You are reverse your answer and you will be correct. Why gallbladder cancer should be painless? You see, painless jaundice, gallbladder can have any presentation, but normally you see painless jaundice?
No, sir.
So why are you saying something which you don't see in your ward? Road, day and night you are seeing the patient. What are the association of carcinoma gallbladder with the stone?
There is it says that 80% of cancers having a gallstone,
So
sir.
80% of the cancer they will have. So
Yes, sir.
the stone will be very rarely it will be silent. So that's why gallbladder cancer and what in your data you must have keeping some data. What percent of the people commonest presentation of gallbladder cancer?
They mostly present with the pain, sir.
So when something is happening mostly, why you want to go which is not having mostly? The question is, you people, when the exam comes, you try to say something which you don't see. If you start analyzing your own points, then you will see that how you are not how badly you are obsessed with this case presentation. The carcinoma, only one important point you said that it is a endemic area for that. That's why I'm saying that it still can happen. I'm not denying that. But the question is, this patient had no pain. What percent of the pancreatic cancer would have pain?
So 2/3 of the patients will have pain.
Will have pain. So 30% of them also might not have, maybe 35% will not have pain. So again, carcinoma pancreas, more and more people will not have pain. Then what about hilar cholangiocarcinoma?
They mostly present with the painless progression, sir.
Painless. And then what about periampullary?
But the presentation of periampullary is also with painless progressive jaundice.
Painless hoga. So if I am at your place, whatever comes, this is your case only, present at
Yes.
your place. So that's why you
Yes,
know
sir.
the diagnosis. That's why so if I have to analyze, I will keep hilar cholangio. Then I will talk about periampullary. And if I have to differentiate between hilar and periampullary, how we can differentiate?
Difference between hilar and periampullary for that
Yes.
thing based on it's not classic. In history, we can ask whether there is a melena is there or not in the cases.
Melena in what percent of the people will have melena in this thing? You people. So what is the definition of periampullary carcinoma?
So within the 2 centimeter ampulla,
All the
region.
4 are there.
Yes, sir.
Out of all the 4, what percent will be papillary type at the ampulla where you talk about melena?
So less
That
than yes, sir. 10%.
So you know that this thing, but you people don't want to analyze critically. So again, it's a very small component of the periampullary can present that also silvery color stool. It's not a classical melena. You should read the difference why it is like that. So the question is, when you are analyzing your history, I would say in a different way. I will say that because it is close to the ampulla, there may be some of the people might present with the symptoms and signs of maybe even mild cholangitis. And second important would be the immediate with the jaundice, there is a start of the pruritus, which is not that common with the periampullary tumor. So if the same patient would have in examination, there will be thing will be different. But based on the history, then you can say that carcinoma gallbladder, because it is endemic in our area, that you can keep it anywhere, but it can go to the third. And cholelithiasis, why are you keeping? Just I want to know.
So it is very unlikely or remote possibilities
So
based on history.
So just because you want to complete the list, then why don't you write that secondary from any GI malignancy?
So
Is it possible?
no, basically, sir, most common
Why?
cause of jaundice is obstructive jaundice is cholelithiasis. So
that's
in
why. Then you should have written on the first. Then why you come to the fifth? When you are coming, right now you said that in our area, commonest cause of obstructive jaundice is gallbladder cancer is very common in our area. So please don't try to mix up the things. Once you are making a diagnosis of malignancy, by and large, most of the time, the differential should be malignant. If you are trying to keep cholelithiasis, then you should have certain points other than calmness. You are not sitting in a theory class. Here you are seeing a patient who never had a pain. What percent of the people with cholelithiasis will not have pain?
Very rare, sir. And
No, very rare. How much? Please tell me how much. So, my dear, what is your name, Rashid?
yes, sir.
Please remember, Rishit, remember, don't try just, it is very bad habit to persist with something you have said. You try to listen and understand and analyze. Cholelithiasis in this patient where there is no pain at all. If you are keeping, then you are just not, you are telling the people who are listening to you that you don't follow what is in the classical textbooks. Even Belly and Love, which we read from MBBS to MS, will talk about pain, jaundice, and fever. What is classical pattern of cholelithiasis?
Generally, it presents with the pain, jaundice, and intermittent pain, jaundice, and fever, sir.
So it can happen. So it doesn't fit anywhere in your differentials. First, you said, I am keeping malignancy because she is 60 years, because she has a weight loss, but you don't know how much. And you have said there is a decreased appetite. Why a benign disease should have a decreased appetite? Why a benign disease should have a weight loss? Jaundice itself can be nauseating and sometimes anorexia is there. But other symptoms and signs should also support your point.
So you keep the gallbladder neck as a first because of the most common in your area, or just you just
Because,
depend on your history? As Sir
sir,
had said, they must have some kind of
yes, sir.
pain history.
Because of because of endemic zone area, sir, or and it is a 60
But
old age.
whenever the gallbladder neck cancer come with the jaundice is already locally advanced. So patient must have the history of fever, cholangitis, big mass, weight loss, even gastric outlet obstruction also. But is here it is not present. And you written in the history, you have written the recent onset of the diabetes mellitus. Why you just uh, stress on the recent onset of the diabetes mellitus in this scenario?
Generally, in cases of CA had a pancreas, there is a change in pattern of diabetes happened. So that's why in negative history, because I don't know the exact organ of origin, so I have asked in that regard, sir.
Good.
So, Dr. Rikshit, it's a
Yes, sir.
carcinoma gallbladder with hilar involvement. So,
Yes, sir.
any other carcinoma gallbladder presentation without hilar enlargement? How do you know based on the history it's only due to the hilar involvement, not due to something else?
Based on history,
You
I
are
cannot.
very specific in your diagnosis in differential. It's a carcinoma gallbladder neck and with hilar involvement. I want to know whether there are other condition of malignant CAGB which can present with obstructive jaundice without hilar involvement. How will you
Yes, sir.
differentiate based on the history? Why you have kept this specifically in this scenario?
So based on history, I cannot completely differentiate with
But you have
differentiate it.
specified very highly specific diagnosis
Yeah,
differential.
that is the point. You specified that the hilar involvement.
Yes, sir, because most of the in our endemic zone area, the presentation of CAG is quite different, varies. So that's why since she is an
So
old
you
age
have to keep
female,
it wide open. You have to differential should be wide open so that you may include everything in your differential rather than it's very specific to have a hilar involvement. It
Dr.
may
Rishit,
what
Dr. Rishit, please listen to Dr. Subhas. What he wants to say that are there other causes of the carcinoma gallbladder presenting with jaundice?
yes, sir. So
how
there is a cause. There is a enlarged hepatoduodenal ligament which is compressing the CBD. There is a first.
Hepatoduodenal ligament doesn't enlarge. This is I think you are talking about nodal
Lymph
involvement in
node
the
involvement.
Lymph nodal enlarged, which
Yes.
is
So you tell
compressing
the
it.
clearly, my dear, don't get bogged down. So
Yes, sir.
his question is, without having any investigation, how you are sure that only Hyler is involved,
Yeah,
not the
Hyler
mid
is very
CBD,
specific
not mid
parameter.
CBD, not stone in the lower end of sorry, not the lymph node in the lower this thing. So there are multiple reasons. So if you write like this, so I was not aware when Dr. Subhash joined. So I was going to ask the same question. So the question message to you is that please try to think when you are writing something. No, why 5 4 5 points you should have in your when you are making a differential. First, the diagnosis should have 5 points favoring the whatever you say, and about 1 or 2 should be against your thinking process. Same way, second, less than that. If you are keeping multiple points which are against your differential, then you cannot keep the first diagnosis. So carcinoma of gallbladder is something which can, in our North and East India, can have any presentation. But for the discussion point of view, in the exams where you are not given, you should try to this thing. Every time, even on Monday clinics, we talk about all these things that nobody is going to ask you pinpoint the diagnosis. But if your discussion is okay, then your work is done. If you have the differential diagnosis, but you are not able to justify, then everybody knows that you know the case. That is very biggest blunder. So I think Dr. Subhash, Dr.
Yes,
This
sir.
thing we can go to examination. Huh?
Yes, sir. Yes, sir. Sure.
Yes, go examination, please.
The patient is well conscious or cooperated and well oriented with time, place, and person, lying comfortably in bed, moderately bit and moderately nourished, and well hydrated. Her height was 160 centimeter, weight was 58 kg, and her BMI was 22.7 kg per meter square. As subjective global assessment was D. ECOG performance status was 1. There was a icterus which was present. There was no pallor, cyanosis, clubbing, or pedal edema. There is no left supraclavicular lymphadenopathy. Her pulse was 84 beats per minute, regular and normal volume. Blood pressure was 140 upon systolic with a diastolic of 80 mm of mercury. Respiratory rate was 18 per minute, and her saturation was 99% on room air. Sir. On examination of the abdomen, on inspection, abdomen is flat and moves normally with respiration. Umbilicus is centrally placed and inverted. Scratch marks are present over the anterior abdominal wall. There is no visible scars, sinus, or dilated veins, or visible peristalsis. Orion sites appear normal with no visible cuff impulse. There is no renal angle fullness. On palpations, abdomen is soft, non-tender, no local rise of temperature, no guarding rigidity, no palpable mass in the any quadrant of the abdomen. Liver and gallbladder is not palpable. No renal angle tenderness, no palpable umbilical inguinal lymph nodes. On percussion, upper border liver dullness is noted in the fifth intercostal space in the midclavicular line. The liver span is which is measured is about 12 centimeter in the right midclavicular line. The rest of the abdomen is resident on percussion. No fluid thrill or shifting dullness was noted. On auscultation, bowel sounds were normally heard. Per rectal examination, anal tone was normal, mucosa is smooth, no mass is palpable, fingers stained with alcoholic stool. On examinations for respiratory system, bilateral air entries are equal, normal vesicular breath sounds are heard, no added sounds are heard. Examination of the central venous cardiovascular system and nervous system was within normal limit. So based on the history and examination, can I summarize the case? Sir?
Yes, please.
Yes. Yes, 66-year-old female with the echo status of 1 with controlled comorbidities, presented with a 1-month history of painless progressive surgical obstructive jaundice with a decreased appetite and weight loss with pruritus, without history of cholangitis, with no palpable gallbladder. She is most likely a case of surgical obstructive jaundice, likely of malignant etiologies.
What you excluded with the inclusion of the examination from your
So, yes. So,
diagnosis?
yes, sir. I excluded the distal obstructions. Most likely see head of pancreas and periampullary carcinomas. It's not completely excluded, but on lower down, sir.
So mostly you excluded the periampullary, I think.
Yes.
So what you included now? So just look for.
After looking at eyes, two probabilities that there is again CAGB with hilar involvement, and second is the hilar cholangiocarcinoma goes up in the differentials.
Okay, so now remains the CAGB and hilar cholangio. So how
Yes.
will you proceed?
No, just for Dr. Ashok, just for one or two points to be clarified. We
Yeah.
should clarify. So you mean to say that all palpable gallbladders are this thing? Sorry, distended gallbladders are palpable.
No, sir.
What
In
percent will
cases,
not be palpable?
so, so
There
in
are
cases,
multiple things which we think about when we talk about gallbladder. Lump in the about the palpability of the gallbladder depends on the multiple things. So what percent of the people, because immediately you have excluded a very important periampulvic cancer and carcinoma pancreas, and you have come to directly to only one diagnosis, surgical after jaundice, because of the carcinoma gallbladder. So kindly let me know what percent will be distended but is still not palpable.
so it's around 20 to 30% in cases of
20 is a
obese.
20 is a very less number. Is, is, is liver palpable?
No, sir.
It depends on the question of the liver. It depends upon multiple things where you can not only that body habitus, a patient which is little bit obese, then gallbladder is not palpable. Very muscular person, gallbladder may not be palpable. If there is a this thing gallbladder distended, but still because of all these things, gallbladder still may not be palpable
But
because of the
here,
location of.
wow, this could be possible, but here the BMI is only 22. So
Oh,
here,
Dr. Ashok,
here,
we are
uh,
discussing about
yeah,
lot
yeah,
this thing. We are not
yeah,
talking about this
yeah,
patient and
that could be possible, but in
all.
case
So,
he may be right.
oh, okay. There is no question of right and wrong. We are
Yeah,
discussing something.
yeah,
No, it's
that could be
not
the
a
possibility.
yes.
Dr. Dixit,
Yes, sir.
how many percent of the patient of carcinoma gallbladder have a palpable lump?
Sir, it is around 50, it is around more than half
Majority,
measure. Yes, sir.
more than 50%,
Yes.
right? And
Yes, sir.
if the hilar involvement is there, what do you expect? GB should be palpable or not?
In case of hilar involvement, the GB is less likely will be not like there's no palpable, not palpable.
In hilar involvement.
Obstruction. Yes, sir. Obstruction.
It depends because this patient, if there is a chronic cholecystitis or long standing, and so GB may not be palpable. But if there is a distended GP due to hilar involvement, GB may still be palpable. So why not you are keeping hilar cholangiocarcinoma at this point of time as your first diagnosis rather than CAGB?
So because
What
still
are the points against hilar cholangiocarcinoma as a preferable diagnosis in this patient?
again, sir, for the first point is that endemicity of the disease. The hilar
Yeah, just
cholangio.
come out of that first point,
Yes,
please. I request you very humbly.
yes, sir.
Dr. Saab is asking very important question. If there is a cystic duct blockage, is it going to happen that gallbladder cystic duct neck is not involved and suddenly goes and blocks the hilum? It will be most of the time the same thing will block the cystic duct and all those things will be blocked. So common duct is most commonly involved. So the gallbladder palpability should be there. If it is not there, it is another question. That very important scientific question Dr. Subhas is asking. So you should answer like that every time you are talking about same thing. See, this is the where there is always a message you give that because I know ultrasound, because I know CT scan, I'm not ready to listen to anybody. This patient has no pain, this patient has no fever, which can happen in gallbladder because it is associated with stone, never had any sign of inflammation, and this patient had suddenly come only with the uh, jaundice which has pruritus is simultaneously starting. So anybody listening, and after examination, when gallbladder is not palpable, in a case where there is a jaundice associated, everybody will think that Hyler should be the first. If you combine all the points, you are only harping on one point, that it is because it is in our area, because you have that point is well taken in the beginning. You have certain things, so please answer the question, analyze and answer.
Yes, sir. For Hyler, in this lady, for the first, I have taken CEGB because of that presentation, the old days, as well as in cases of there is a chronic inflammation when the patient will have, the gallbladder will be not palpable. And also in cases of CHGB, which is neck involving the cystic or CHD, in that situations, it is not absolute that all the cases will have palpable gallbladder, but this type of presentation can happen. But in cases of hilar cholangiocarcinoma, the patient will have painless, that which is present in this case, which is having progressive jaundice, also present in these cases. And on examination, the gallbladder is not palpable. So points are favoring of hilar cholangiocarcinoma is there. More in hilar cholangiocarcinoma is there, sir. If it be CHGB, lacking histories that, or there is no history of recurrent pain or having a pain, which happens in the background of chronic inflammation due to stone. So that is point against my first differential, that is CAGB.
So our point of discussion is still it can be anything, but our vision should be clear what we are dealing with. Still on the investigations or any other imaging, we can see it can be anything out of your differentials, right?
Yes, sir.
So how will you proceed with this case now?
I will proceed with this case with routine blood investigation, in which I want to send the complete blood hemogram with the liver function test, renal function test, prothrombin normalized ratio INR, and CA19-9. Along with that, since patient having history of hypothyroidism, so I want to show you on a fasting state of thyroid function test in this lady.
Any
After
other
that,
blood investigations?
any other, I can ask for the fasting blood sugar.
Okay. Anything else? Okay, I'm asking a direct question. At what point of time you are sending the tumor markers?
So, in cases of obstructing jaundice, there is a false elevation can happen in tumor marker. So, after biliary drainage, generally it should be sent. But
What tumor marker you do after the decompression of the biliary system,
see,
or not do?
so generally CA19-9 we used to do, sir.
Yes.
Okay, so suppose if there is a not related to this, if there is a periampullary CA bilirubin of 10 operable, so you don't want to send the CA19-9 in
Yes,
patient?
yes, I want to send it, sir,
You
because
told you have to drain first in all the patient, then you want to send the CA19-9?
No, sir. We have to send because the some value, higher values having significance on of aggressive malignancy
What
or
is your institute protocol of sending CA19-9? Is there any cutoff below which you are sending, or you are sending in all the patient prior to surgery, or you are doing in all the patient after the drainage?
in our practice, sir, we used to send when the patient get admitted in our ward after in a first investigation when all the blood investigation are going to send, sir.
Okay. Now, what else?
So my only one question I want to ask at this point, otherwise Dr. Subhas and Dr. Subsi. So you don't want to have a diagnostic investigation that I should have in my mind what I am dealing with. You are sending everything, then waiting for 2-3 days, then you want to make a diagnosis.
No, sir. I can. Since the patient has get admitted, the blood investigation will be drawn and sent. Then after that, I will
Okay.
ask ultrasonography of the whole abdomen.
So, my dear sir, you are very rigid person, and I think you are to stuck up with your own ideas. But in examinations, we always think about diagnostic investigations and investigations which are helping to prepare the patient for the surgery or chemotherapy or any other thing. So, if you putting one probe on the abdomen, will clear so many things. So we are not going to wait for everything to come. That fasting will come. I will set samples. In OPD people have ultrasound by the side of the room nowadays, and most of the surgeons also they are doing ultrasound. There are departments where in the ward there is ultrasound machine. So the question is, when you are talking about this patient has no pressing thing to prepare. She is comfortable. She has no jaundice. She has no anemia. So don't you just can say that diagnostic investigation. I will do ultrasound, and for my preparation I will do this. And just what Dr. Subhas asked the question to you about the CA99. There is a corrected value. Please go and read. I'm not going to tell you this. There is a corrected value of the CA99. So when we see CA99, one is that elevation. Second is that if there is a cholangitis, there is another way of calculating the corrected value. If there is only jaundice, then is another way of getting the corrected value. It's not that you only drain when patient become normal, then we'll send. There is a way to do it. So if you do something comes, you go and try to have the corrected value.
Especially it's work when you have a controversy in the diagnosis. You have clear-cut diagnosis on the basis of the history and investigation, imagine investigation. You may not rely on these uh, tumor marker. Then you have to be very careful when you have a doubt that it may not be the malignancy and you're planning for the very extreme kind of complex procedure. We have may have a complex kind of the complication. In that situation, you require all these things. So I think first you should tell the LFT what are the labels.
There is a raised total bilirubin with the direct bilirubin component is 9.46, total is 10.5, and SGOT and SGPT is 92 and ATT, and there is a raised alkaline phosphatase label. Her rest of the complete blood counts in TLC is normal, and there is INR, PTNR is also normal, sir, and renal function test is also within normal limits.
So, what is your interpretation of this LFT? You don't just read it. What is your interpretation after seeing this?
Yes. Based on this LFT, it is showing that it is an obstructive pattern of jaundice with mildly elevated level of SGOT or ATP, sir.
Total protein has not been calculated. Does it make any difference in the thinking process?
Yes, sir. Nutritional status and albumin is included. It is on a lower side, 3.22, sir.
What is the reversal of the albumin and globulin ratio?
So I have not taken in the slide, sir.
No, you know it or not?
What is the importance of reversal of the albumin globulin ratio?
In cases of sorry, sir, I don't know, sir.
Okay, so the LFT, all the blood investigations are done. Now you want an ultrasound or CT scan?
So, ultrasonography patients, sir.
Why? Why not CT scan?
So ultrasonography is done to the locate of the level of the obstruction. Since the history and examination, we are not able to sure what is the level of obstruction. So that's why and
CT won't show the level of obstruction.
CT will show, sir.
So what is the advantage of the ultrasound?
It is, sir. advantage, it is easily available. It can be done without the waiting for the
It
renal
is
function.
also easily available nowadays everywhere.
Yes, sir. It can be done without waiting for the renal function test, and also
Okay.
there is no contrast is used, so it is also not
That is
a
the only
proxy.
benefit of ultrasound.
Yes, sir. So,
Can you avoid the CT scan by doing the ultrasound?
no, sir.
Never.
Why?
Never.
How
But
many patients of the CAGB presented with the metastasis?
Yeah. Suppose the patient have a gross metastasis in liver, all low.
that in cases of there is a gross metastasis and there is a gross ascites, this we can go for only ultrasound and then counsel the
So
patients.
it could be important.
Yes, sir.
So you can avoid CT scan in such advanced cases. Okay.
Yes, sir.
So what is the ultrasound finding?
Ultrasound findings suggestive of there is a intrahepatic biliary radicals are dilated. Distal CBD, which was visualized, is normal in caliber. There is no acoustic shadow, and gallbladder is contracted and poorly visualized. There is no calculi, and wall thickening was noted in gallbladder. Rest is pancreas is normal, and there was no ascites, and there is no lesion in the liver.
Okay. So where is the pathology is?
Pathology in the high, most likely on the higher side of the biliary duct, most likely around the hilum or GB, most likely around the hilum, sir.
Okay. So what next?
So why are you saying most likely in the hilum? Why then you should question the ultrasonologist. He has mentioned that there is a dilatation of the intrahepatic biliary radicals. Then he said that distal CVD appears normal. He has not talked about the mid CVD. So how you take this message that it means that in between there is a obstruction? When ultrasoundologist has not mentioned, it means either he said inadequate ultrasound, or you take it like that. If you take that, this should be normal. Because if they are able to see the in the distal CBD, doesn't give any message to you that proximal to that there is obstruction in between the intrahepatic and the distal CBD. This message you want to give.
So
No, sir.
Then
Mm.
he has written intrahepatic biliary radicals are dilated bilaterally, more permanent on the right side. Then he said distal CBD appears normal in caliber. No calculus or mass lesion seen in the distal CBD or pancreatic head region. However, in between, he has not mentioned anything about the common bile duct. So, does it give to you this message that in between there is obstruction?
Based on this, the obstruction may be at hilum or in the mid CBD level or CHGB neck level. It can be there, sir.
Then,
It
how
cannot
will
be.
you see the distal CBD? What percent of the people will you are able to see the distal CBD without having bile at all in that CBD? The question is very this thing. Either you say that this particular ultrasound has not talked about this thing, but taking the message from this ultrasound that blockage is there in between, but they have not discussed it.
In it.
And one more thing, he was able to describe the main duct, pancreatic ducts was not dilated. It's very difficult to see on the ultrasound, but it's good if we have the idea of the duct. Now you can exclude?
Yes, sir. The in cases of CA head of pancreas or other than distal CBD, periampullaries, other groups can be ruled out, sir.
So,
Till now.
Till now, not completely, but yes, sir, we can.
so what message is that this gallbladder is contracted and poorly visualized?
It having either due to it may be either the hilar obstruction or there may be a chronic inflammation in the gallbladder. That can cause contracted state. It may be CAGB neck or which is involving. So gallbladder is in that situation become chronically inflamed and contracted. So it is still not clear whether this is obstruction either at hilum or below hilum between the gallbladder insertion points based on this ultrasound. It is only the lower portion is a little bit excluded, while upper portion is still open because it is not completely covered, sir. That's why, sir.
So here he has written the gallbladder is contracted, poorly visualized. Both are contradictory, and here no calculi means no wall thickening. What you think? What it could be? May not be the wall thickening. He has said is contracted, but wall thickening तो है ही नहीं.
This is most likely the limited study, or he maybe have. When it is not visualized, you can't comment. Maybe some expert, but
Both are the contradictory. The gallbladder is contracted, poorly visualized, maybe poorly visualized, but
yes,
wall thickening is not present. What happened when you go to the radiologist for your ultrasound and you have already eaten some samosas and kachori in the morning? What happened with the gallbladder?
they get collapsed.
That could be
Yeah.
the possibility because
Mhm.
it
Yes,
have
sir,
not
first
mentioned the
actually.
wall thickening at
Yes, sir.
least. So
So tell what next I want to do.
I want to proceed with the contrast enhanced computed tomography, the triphasic scan of the whole abdomen and thorax of the patient, sir.
So in a patient where everything, these are the things not seen, what is the better investigation to see for bile duct, common bile duct and jaundice and all those things? MRI with MRCP or CT scan would be better?
So, magnetic resonance imaging with the MRCP will be better in cases of that will deal most of the thing. In
I
cases
did
of
not say only MRCP. You listen only MRCP. I talked about whole abdomen MRI with contrast and MRCP.
yes, a contrast enhanced MRI with MRCP uh, can address the biliary obstruction as well as the
No,
vascular assessment.
why you talked about CT scan? No mass lesion is seen anywhere. Suppose there is a mass lesion in the pancreas. Suppose mass lesion in the hilum. Here you are seeing a patient on ultrasound. That nothing is seen, but still there is a IHBR is present, and we don't know where the blockage is. Which investigation would be better?
If one, I have to choose the contrast enhanced MRI with MRCP that I will choose.
Then why you are telling of CT scan first without MRCP?
So, since we don't have the exact idea whether it is a CAGB or it is a hilar cholangio, so we went for the contrast enhanced CT scan of these patients first, sir.
So suppose I do MRI, then it will not clarify whether it is hilar or block. So you are at this. The thing is that you know the diagnosis. So every time you are hilar block, by no means by this ultrasound, at least I might have less IQ. At least I am not able to interpret that there is a hilar block because ultrasound is inadequate. He has not described anything, whether there is a up to what level bile duct is seen. He has gone to see up to the pancreatic duct. He can see distal bile duct, but he did not talk about bile duct in between. Either he should written that the level of the blockage is this, and beyond this we are not able to. It's to see the come bile duct. Bile duct is it is better seen proximally than when it goes behind the duodenum. So if I can see behind the duodenum and he's not able to see above the duodenum and between the hilum, then he should mention it. So I will take it as a inadequate imaging, and then try to have a imaging which can show the bile duct properly and everything, so that we should know where is the obstruction. And for that matter, to my mind, our two moderators can give their opinion. It is better that we should do MRI because we have to use the resource which is limited. We cannot go on asking one after another. So ultrasound, CT, if
Definitely,
some,
sir.
yeah,
MRI is a better option if the blockage is
uh,
high. In the
yeah,
hilum, or you are suspecting a ductal separation, you want to see whether the
yeah,
secondary is involved or not, whatever it is. And if you are dealing with a distal CVD, then you can proceed with CT scan without MRCP or MRI. That is a difference. But in this patient, we even don't know exact site of obstruction. So better to go for
yes.
the MRI with the MRC, MRI with the MRCP. That is a
Yeah,
better option.
that would be the better option in the combination. I think so let's start with the CT scan. If you're more familiar with the CT scan, you can exclude the other diagnosis also. Ultimately, it's require some kind of the cholangiogram like MRI. So for planning
So the
and
CT scan,
everything,
whatever has been done.
yeah. So how will you proceed? The CT scan or MRI or both? Which
Uh,
first?
First, I will go with the CT scan, sir, because one I have to choose, then I have to choose the contrast in MRI with MRCP.
So 3 you have to choose, then you will choose MRI, CT scan, and PET scan. And 4, if you have to choose, then you will also choose US. Your answer is very, very not pleasant at all. Your way of answering is very unpleasant. Please let me tell you on your face, because you are going to appear in the exams and anybody will be examiner. So once you can say that I agree that I will see MRI with MRCP might be better, but in our center CT scan has been done. Would be pleasant. But you say, if I have to choose one, I will do, but I will do a CT scan. It gives a message that if you have done a CT scan, but I have to choose only one, then this thing, then I am ready to go for another. Then I am ready to go for another. This is not the exam. Exam is preparing you for a proper surgeon which can benefit the society. Not that you go on, it's not a Pandora box, you start lifting everything. So we should know to you how you are proceeding a case. So that concept that we are more familiar with CT scan is gone. Nowadays, such a good MRI is present, and even our agent, we also go to MRI room, see different things. If you are require MRI, we have no idea of common bile duct. We have no idea where is the blockage. For that reason, one shot CMRI with this will be appropriate. And if somebody is very required vascular resection and all, he might go for reconstruction, but same reconstructions is available in MR. However, there is a slight edge of the recon images on the CT scan. So that
So you
era, yes.
Yeah. So now you could have a two objective. One is confirmation of the diagnosis, whether it's cholangiocarcinoma. When you have a doubt of the cholangiocarcinoma on the CT, you may proceed for the MRI cholangiogram. And second objective is to planning for the surgery. Suppose if you have a cholangiocarcinoma hilum, what you will do? What you plan your surgery? What surgery you plan?
No, I think that's at the CT scan before going
So,
to surgery. Please
yeah,
show the CT scan. Whatever you
that's
have
right.
done, show.
That's right. So you have to keep all these two things in your mind. First thing is the diagnosis. Second is the planning for the surgery and how you proceed. Which first do you like to do?
Please
So,
describe the CT scan.
yes. This is the axial section of the patient CT scan. Scanning from the thorax. There is no SOL or pleural effusion or patches are visible. When you scroll down, there is a calcification in the aortic wall, and also
What we are seeing, we are not seeing. Where is the
Is
aorta calcification in the
actually,
wall? The aorta is very nicely enhancing. You did not tell us what type of picture is it, whether it is arterial phase, portal
or
phase, plain CT scan. What is this?
non-contrast CT scan in the axial
So
section.
what is aorta? What is above this vertebra?
This is the
Is it
aorta, sir. This
This
is
is
the
aorta. It's not enhancing. Then what is there in the aorta if there is no contrast given?
so this is the calcification in the aortic valve, sir.
Oh my God.
Calcification.
But
What are you talking,
it's
man?
also seen in the
Atherosclerosis.
lumen.
So that
You are
is
you are seeing, just listen here. You are seeing the vertebra there. Do you think that the value of the both is same? You are seeing aortic calcification, then there is a calcification in the liver everywhere. There are some dot things in the
Yeah,
in the
yeah, yeah.
liver.
See
They
the
are all
aorta also.
calcification.
The aorta is filled with the white.
atherosclerotic calcifications are there, sir.
My dear sir, I request you very humbly. I cannot be very rude to you. Please don't talk like this in as a MCH student.
And see
Please
the
don't
dot.
talk like this. I
Yeah,
am telling you, you have to see the Huntsville unit. You can see the calcification, ribs and vertebrae and those things and aorta. Do you think these are the same? Opacity which you are seeing is same. For calcification, it should be same.
and the dot in the liver in the combination black and white. What are they? Can it appear on without contrast CT scan?
Can you
Or
go a
CT?
little, because only 5 minutes or more. I started at 3 and I will finish at 4. I cannot go even 1 minute beyond that. Please show some more pictures or we can close it.
So yes, sir.
This is the only picture you have.
No, sir.
Yes. You said I am scrolling down but this thing I am seeing. Where are you scrolling it?
I'm not able to see the scrolling.
Yeah. We are
It's
not
a
able to
still
see.
picture.
We are only seeing one still picture.
Take one, sir. So it is visible, sir.
No.
No, we are seeing one still picture. That's all we are seeing.
Yes, 2 minutes.
Dr. Risip, you should always
Yes.
mask the patient details in your presentation. This visibly.
Now you are seeing what? Something you are seeing here. What is that?
Yeah, yeah. Let's move this.
Same spherical thing is seeing about the just left to the vertebra.
Yes, this one.
Not that one. That is spherical thing.
This one, sir.
Spherical thing.
This
Left.
is
Yes,
Yes.
this one.
What is that? What is that? You are keeping your pointer there. What is that?
this is aorta, sir.
Whatever this you are
So,
think you are see you think that this is calcified.
Yes, sir. Just see carefully.
Go down.
So quickly see what are you seeing. Please go on telling.
yes, sir. On a lung, at this sections, here we can appreciate there is this is left duct which is dilated here, and on the right side there is a dilatation of the biliary radicals on the right side is also there. When we trace down,
So
this
is a arterial phase or venous phase, because you say it is plain, but I am not accepting that. What phase is this?
it is a portal venous phase of the
Where
axial
is portal
section.
vein getting this thing?
This
What
is the
happens
portal.
in portal venous phase? Okay.
This is the portal venous.
Hmm.
So when we trace it up, there is a bifurcation of the portal
So
vein.
normally what we see plain CT scan, then we go see the arterial phase, and it is mostly arterial phase, and then we talk about portal venous phase.
Yes, sir.
Hmm?
Yes, sir.
So still you are sure that aorta is calcified. So to see the calcification, you should have a plain CT picture, which to our mind is not there. Go ahead,
So,
go ahead, because it is
Go
good
down,
2-3
go
minutes
down.
more left. Please.
yes,
Yes, proceed in same video. Yes.
yes. So, this is the enhancement circumferential. This is a circumferential enhancement of the CHD, which is when we tracing it proximally, it is dividing into two branches. This on this side, this is left duct. This is the right duct. And when we traced a little bit higher on the right side, it is enhancing till this point. When we trace the ducts of the this when the taste
Please
the
calm down. Please calm down. So
when
where
we
is it is not seen? Is there some area where it is not seen? It is
this is the distal portion of the CBD which is not enhancing. There is a this is the distal portion.
so what is that? Something here in there?
Yes, sir. There is air pocket around the maybe diverticula is there, sir.
Diverticular? Where is duodenum?
This is the when we polish. This is the duodenal bulb. This is the segment of the this is the duodenal
Okay.
Yes.
lumen
Hmm.
is there. This may be duodenal diverticula with air, sir. And when distal CBDs, there is no enhancement in the CBD wall. When we trace it proximally, the enhancement has started here. When you trace it proximally, this is the enhancement, and it goes towards the
Where is the blockage? You are talking about enhancement. Where is the blockage?
so the enhancement is involving the both the hilum as well as the CHD and upper duct, sir. As such, in this area, this area, the lumen is not barely appreciated, but
Can you show the GB at that level?
yes, this is the GB, sir, which is
Contracted.
contracted state, sir. And the extent of this enhancement, when we trace it on the right side, it is going
Okay,
at this
please go
level.
down. Please go down. There is a. So what is this structure where there is something is seen in that area? Just superior to that where you are keeping your this thing. Can you go
This
to the
Above
good
this.
portal vein here?
this is the portal vein, sir.
What is behind the portal vein? Are you seeing something behind the portal vein?
Yes, sir. It is most likely SMA, sir.
Yeah, SMA would be toward the left of the portal vein. We are talking about the SMB. We are talking about something behind the portal when you are saying that the some structure. Can you go to better portal vein picture? Otherwise, time is getting wasted. Please go to another better picture of the this thing. Better cut and let us see again.
This is the picture. Venus face. Let me see.
So now this is a classical portal venous phase. That picture was because liver is enhancing properly, spleen is enhancing properly. When portal venous phase, there is a good enhancement. And then now tell us where is the block.
So this is the left duct, this is the right duct. When there is meeting, there is a CHD's formation here. Uh, and here is the duct is not visualized. And below that,
Okay.
there is again appreciation of the duct. And there is an
Okay.
enhancement of the ductal wall.
So go down little bit, please. Come down.
Yes, sir.
More.
When we trace it, yes.
So what is that between the portal vein and common bile duct? Behind the portal vein, some structure is seen. Okay, please go to the report because we have already 3 minutes more gone.
It is arising from the sir aorta, most likely SMA, sir.
Okay, what is the finding? CT
Yeah,
report finding.
CT report, yes.
So Sir, visible, sir.
Hmm.
Yes, sir.
Yeah.
There is enhancing superficial mural thickening involving the proximal common bile duct, common hepatic duct, primary biliary confluence, right and left hepatic duct with extension to the right secondary confluence. The confluence of the segment 2 and 3 ducts are on the left side that is preserved, also with a mild bilobar intrahepatic biliary reticle dilatation. The mid CBD measures about 8 mm and gallbladder is poorly visualized, likely contracted. There is pancreas, there is subsymptomatic lymph nodes in periportal and portal
So that was
regions.
what I was talking to you. What are you seeing behind the portal vein? You are seeing that there is a this. Okay, go ahead.
So with this cancer or with the reports?
No, now
Yeah.
what is your diagnosis?
So based on history examination and imaging finding,
This
he's
is CT scan. Yaar. Why are we here? Now this is a diagnosis.
he
Now
is
we are
of
not
high.
going to history.
Yes, she's a case of hilar cholangiocarcinoma
So
with extension into the right duct, most likely bismuth correlate classification type 3A, sir.
So
okay.
what surgery you would do in this?
So, this patient requires major hepatectomy with bile duct excision with in a chordate lobectomy and in block with lymphadenectomy, sir.
And second thing, I just want to know, so whether you want to just document the histopathology or just operate, tell the patient you have a cholangiocarcinoma, the common duct and right duct, and you want to do the some extensive kind of surgery.
Sir,
Lesion.
when the CT imaging features suggestive of malignancy, the histopathological confirmation is not required for.
Is it possible may not be the malignancy? Suppose patient may not have a malignancy on the specimen and patient have a severe kind of complication in the post-op. What you do?
So, preoperatively, we have to counsel the patient, but regarding that,
Counsel to जब करोगे when you have done your effort. Without doing your effort, you have not done an effort. I am going to do this, and this could be the possible. You may have a major grade of the complication, even grade
yes.
5 complication.
So tissue diagnosis is not routinely recommended for hilar cholangiocarcinoma, sir.
So
तो आप क्या करेंगे अभी बस 2 मिनट बता दीजिए कि आप क्या करेंगे व्हाट इज
करोगे
दिस
आप
सीटी
ऑपरेट कर
स्कैन इज
दोगे
देयर
कि whether you do
नाउ दिस सीटी स्कैन इज इन फ्रंट ऑफ यू नाउ व्हाट इज
MRCP
योर प्लान
करोगे कि नहीं? Will you do the MRCP or
Yes,
just
sir.
operate? You're
No,
very
sir.
eager to operate the patient. What you do?
I will do the MRCP for the know the portion of the uninvolved duct which is on the left side, sir.
Dr.
CT
Rishit, now what is your plan for this patient? You do
This patient,
MRCP, go straight away operate, or you will prepare something. Just please summarize in 2 lines, at least from my side. I will close the discussion after that. Then if you
Yes, sir.
both, my colleagues want to carry on, they can do it.
Sir, after ruling out
You
the
have seen
system.
the CT scan. Now you are the CT scan.
Yes, sir.
At least I am not very clear which type of bismuth correlate it is. So what will be your next plan?
In this patient, after ruling out the
In
systemic,
this patient only.
after ruling out the systemic meds, we will consider the patient
So
for
how will you rule out the systemic effects?
consider for the patient for PET CT scan, sir.
Okay.
You go all the patient for the PET CT in this scenario, or in selected patients.
In selected patient when there is a
So what is the indication of PET CT in this patient?
First thing, you should decide whether this the lesion is a malignancy. Then you look for the metastasis. When you have not decided, you have not confirmed this is malignancy, and looking for the metastasis, the lesion look like a metastasis, may not be the metastasis. That could also be the inflammatory.
What is the guideline NCCN guideline says about the PET CT in CAGB recommendations?
Especially in hilar block, CAGB, it's not this thing.
Yeah, CAGB with
Recommended.
hilar blocks.
We are talking about hilar cholangio at least
Hilar
biopsy
blocks.
imaging.
Yes.
Yeah.
NCCN doesn't routinely recommend for PET CT in hilar
So
cholangiocarcinoma
why
because
you are proceeding with the PET CT in this patient?
we are planning some major hepatectomy which having a major post-op complication. So to ruling out whether the patient will have systemic mets or not in that
तो
What is
situation.
आप इसमें सीटी स्कैन करेंगे, एमआरआई भी करेंगे, पेट स्कैन करेंगे, उसके बाद क्या करेंगे? चलिए अब आप जो मन चाहे करिए, अभी बता दीजिए क्या करेंगे, सो दैट वी कैन हैव समराइज एंड क्लोज इट।
वॉल्यूम तो किया नहीं आपने?
उसके बाद क्या करेंगे?
Since the patient is planned for major right
यार सिंस पहले बात कर लो यार, पहले करोगे क्या?
right
सिंस बाद में करना, क्या करोगे?
this patient required major hepatectomy. First
यार
biliary
व्हाट
drainage.
इज डेफिनेशन ऑफ मेजर हेपेटेक्टमी? व्हाट सर्जरी यू आर गोइंग टू डू इन दिस पेशेंट?
This
व्हाट इज योर प्लानिंग?
my planning in this patient is right extended hepatectomy with chordate lobectomy with
So just listen please. So her bilirubin is 10, her albumin are toward the lower side, and then you said that ECOG 2, sorry, and then you are going to do straight away major hepatectomy without knowing the volume of the liver, without even assessing what is the involvement in the MRCP, and then you are going to do major hepatectomy without any further preparation. Huh? So
in
to my mind, listen now, listen. I am repeatedly ask you. I did not ask you what surgery you are going to do. So this patient, you are in a 10 bilirubin, you are going to do right extended hepatectomy with the cardiac lobectomy without any idea of the liver volume, how much it is left, and the remnant volume, and without talking about lowering down the jaundice. So it might be this your center protocol. At least from as a moderator, I can suggest you. With the other my colleagues can give by their final comment. I can tell you that please go and read CT scan properly, and then think about that. And this patient requires, at least in most of the centers, people will not do right extended in a patient of 10 bilirubin. People try to bring it down to about 3, make the albumin at least more than 3.5 or 4, and then see other parameters. Patient will bring up the patient, do a chest physiotherapy, prepare properly, and then discuss, and then go for the surgical this thing, and staging laparoscopy is most of the time recommended, but that can be debatable. So this is what will be my final comment. So Dr.
Even,
Subhas and Dr.
yeah,
Ashok can
yeah.
lead there.
Even I also suggest, I want to suggest that we should try to get the some kind of histopathological confirmation, or at least you show your intent you have right. Just do, you can suggest the spyglass also if you have a facility, and then you should try, because the thickening in the right duct and the common confluence also there is thickening, but in the middle of the CBD and distal CBD is not normal. There is also some inflammatory reaction. It could be the generalized inflammatory reaction, could be some major reaction causing the thickening, obstruction of the right duct confluence, and some other way the distal and mid CBD is not pristine. So I have a doubt. So I could try to just find out my doubt to clear.
Agreed, sir. I feel in this case there is something unusual presentation. The thickening is bit unusual. The GB is not visualized, clearly visualized. So in this scenario, I think we can do a lowering down of the bilirubin first, followed by volumetry, proper volumetry, and then if the suspicion of malignancy is high, we can go for the upfront surgery. And if suspicions of malignancy is low, we can further investigate like spy glasses or bile cytology or something else, and then we can proceed with the surgery.
Yeah, we recently have observed these kind of the pathology in our patient that have the case like you, and came out the inflammatory pathology as
Yeah,
disease-related
there is a
pathology
possibility.
also. Yeah. So because the CVD abnormality is not limited with the confluence and the right duct, it's also abnormal at the mid and the CVD. It is not just the dilatation, there is thickening also, distortion of the wall.
Yeah. So my suggestion is you cannot do, Dr. Rishif, you cannot do all investigation in all the patient. You have to use the investigation selectively. You cannot do CT scan in all the patient, MRI in all the patient, PET CT in all the patient. There you have to go sequentially.
Yeah,
It is,
yeah. Very mindfully, you should utilize all investigation. Recommendation guideline is to guide you. This is not the instruction to just order to do this. So just guide you. So how you take the decisions, it all depend on your wisdom, your mindful decision, observation, investigation, history, all is depend. So it should be taken very carefully.
I think Dr. Vaibhav and Dr. Basan Narayan is there. If they have any comment, they can come. Dr. Vaibhav Vasane and Dr. Basan Narayan.
Hello,
Yes,
so can you hear
Vaibhav.
me?
Yeah,
yeah,
Sir, I
sorry,
think
you were
yes,
not
his.
available, so I assigned it to Dr. Subhas, and you
Thank
were
you so much,
available.
sir.
You said you were not
Actually,
available.
actually, I was traveling, that's why I could not do it. But I
Okay,
was
good
like
to
there in the
good
session,
to have
sir.
you.
I think he should his history and differential diagnosis was also not properly. He could defend his
Yes,
diagnosis,
yes.
so he should he needs proper learning how to defend his differential diagnosis and then how to read a CT scan. He needs more you need to work hard on his presentation skills as well as learning CT scan. This is my comment, sir. Thank you.
Dr. Basan Narayan. I think, as per my opinion, all the moderators actively tried and tried to help you, but still you were not getting to the point and getting in the stream of the case. The road was very bumpy for you, and you have to work hard. But don't get disheartened, and you will always get all the resident MNCH residents usually get one case of usually malignant jaundice. So these cases we don't expect from North Indian student to make mistakes like you are making, keeping diagnosis DDs not in order. When you have classical presentation of cholangiocarcinoma, you should accept that. That's okay. You can keep carcinoma gallbladder as second, but you had patient who had classical presentation, painless progressive jaundice. In history, it is okay, you can keep that order, but after examination and all, you should have kept that thing that everybody pointed out. So I think you should go to your teachers and discuss this thing. Some basics principle you are not following. Rest is okay. Thank Dr. TD, Dr. Ashok, and Dr. Subhas for active moderation. And next presentation will be on first Wednesday, 8 a.m. 1st July, Wednesday, 8 a.m. by Jipmer Puducherry, and it will be moderated with me by Dr. Harjeet and Dr. Anand Narayan Singh. Thanks, everybody.
thank you, sir.
Thank you,
Thank
sir.
you, sir.
Thank you. Thank you.